Hello, everyone. Welcome back to my presentation. Was the first presentation satisfactory? In part 1, we learned about the concept, terminology, history, and development of hydraulic bioceramic materials. We are now moving to part 2, which deals with the clinical application of it. As I mentioned before, the hydraulic bioceramics gained lots of attention because of its favorable biocompatibility and sealing ability, even in the presence of moisture, such as blood. In other words, it can be applied successfully to the site adjacent to soft tissues containing blood or tissue fluid. Therefore, it can be used for root end filling, perforation repair, root resorption repair, apexification, and vital pulse therapy. First, let me show you a couple of clinical cases of root end filling during periapical surgery. The patient complained persistent pain and sinus tract was found even after non-surgical endodontic treatment. The first radiograph shows periapical radiolucencies on the medial and distal root of right lower first molar, even though the root canal status is very good. After flap elevation, the roots were resected 3 millimeters and inspected with the micrometer. You can see the mediobuccal and mediolingual canals on the resected root surface. I prepared the retrograde cavity using ultrasonic tip, and I filled the cavity using mixing type gray MTA. If you take a look at the post-op X-ray, the filled MTA is clearly visible. After 1 year, the radiolucency was completely disappeared, and they found that the problem was solved. Let's see the next case. The medial root canal was underfilled because of the previous ledge formation. Consequently, you can see the periapical lesion on the medial root apex. To overcome this problem, periapical surgery was planned. Please watch this short video clip. You can see how the root end cavity is filled with MTA successfully. I used the manual plugger I showed you before. After 1 year and 3 months, the periapical lesion was completely healed. Next, I'm going to show you some perforation repair cases. The maxillary second molar needed root canal treatment. After access cavity preparation, during the working length determination, the perforation was recognized. Therefore, the perforation site was repaired using MTA. Please watch this short video. The perforation site was visible under the microscope, and the site is filled with MTA. Please note that a specified designed instrument I showed you before was used since the perforation site was located deep in the root canal. I plugged slightly with a paper point. After the completion of the root canal treatment, you can see the successfully repaired root perforation in the post-op X-ray image. I'm gonna show you another interesting case regarding perforation repair. A young male patient presented with dull pain, and he felt bad taste on his right lower second molar. A sinus tract was found, and it was originated from the mid-root level of the mesial root. While I was obtaining his past dental history, he had orthodontic treatment with mini screw for anchorage. To get three-dimensional information, CBCT scans were obtained, and the defect was found on the mesial root surface. Obviously, it was due to the damage done by orthodontic screw. After finished the root canal treatment, I decided to do intentional replantation to repair the perforation. As you know, it is almost impossible for clinicians to do periapical surgery of mandibular second molars due to anatomical factors. After extraction, the defect was identified and filled with MTA. Also, the root end filling was done with MTA and tooth was replanted. If you take a look at the post-op X-ray, you can find adequately filled MTA. After 2 months, 5 months, and 1 year, the patient didn't have any symptom and there's no periradicular pathosis. I'm going to show you the case how the premixed bioceramic material was used to repair the perforation. This case was published in an endodontic journal last year. A woman came to my clinic complaining of a facial pain. She told me that the pain increased when she bended over or ran onto the treadmill. The diagnostic X-ray image did not show any pathologic feature at all. To obtain three-dimensional information, a CBCT scan was taken, and a big mucositis was recognized. I also found a root perforation as well. Actually, this type of sinusitis is originated from the endodontic problem. So it is called maxillary sinusitis of endodontic origin. So we can call this MSEO as an abbreviation. Anyway, non-surgical root canal treatment was performed and the perforation site was found. I placed a premixed bioceramic material on the site and plugged gently with a taper point. If you take a look at the radiograph, you can see the well-placed bioceramic material. I did root canal filling, and the patient's symptom disappeared completely. After 6 months, the patient did not have any symptom, and the sinusitis was completely healed in the cone-beam CT scan image. Let's move on to the vital pulp therapy cases. The vital pulp therapy includes pulp capping, partial pulpotomy, and full pulpotomy. In fact, the premixed bioceramic material is the material of choice, I think, for the vital pulp therapy. In my opinion, it is very easy to use and the results are very good. The right upper second premolar shows the proximal caries on the distal surface. I removed the previous restoration and caries, but unfortunately the pulp was exposed on the axial wall. After adequate hemorrhage control, I injected the premixed material onto the exposed pulp. Then I placed a wet cotton pellet on the material for 3 minutes to induce hydraulic reaction. As a very important step for initial setting of the material. After around 3 minutes, the material sets initially and the material was ready to receive dentin bonding procedure. After applying the matrix, dentin bonding procedure and composite resin buildup was performed. In the post-op X-ray image, you can see the cavity is successfully restored and the pulp tissue was protected by the bioceramic material. After 1 year, the restoration was found to be intact and there's no pulpal and periapical pathosis. Also, the pulpal status was normal. The bioceramic also can be used for partial pulpotomy. The lower first premolar had extensive dental caries because of the presence of dens invaginatus. Actually, conventional root canal treatment might be required, but the root canal anatomy is very complex. As you know, the divided root canals are very hard to manage. In this respect, I decided to do partial pulpotomy instead of pulpectomy. During the removal of the caries, the pulp was exposed. I removed the surface of the pulp and placed the bioceramic material onto it. You can see the well-placed material in the post-op X-ray image. After 3 months, reparative dentin formation was found underneath the material, and the thickness of the reparative dentin increased a lot after 1 year. It indicates that the pulp is well protected and the pulp maintains vitality. Let's move on to the final case, root canal filling. As I mentioned previously, the premixing technology provides the bioceramic material an injectability so that it can be placed easily into the small anatomical space, such as root canal system. owing to the premixing technology, the root canal filling technique could be significantly simplified. After placing the bioceramic sealer into the root canal, only a single gutta-percha cone is inserted. Then, the gutta-percha cone is cut off at the orifice level. We call this technique sealer-based one because the most part of the root canal is filled with a sealer, not gutta-percha. You can see the nicely filled root canals on the left X-ray image, and completely healed furcation lesion after 3 months on the right X-ray. However, some clinicians ask me that why we should use bioceramic sealers. We can get high success rate just with resin-based sealers until now. Yes, I totally agree that clinicians can still use the resin-based or even ZOE-based sealer as well. Before I say the advantage of the bioceramic sealers, I would like to introduce an international survey on the use of calcium silicate-based sealers in non-surgical endodontic treatment. This article was published in 2020 in Clinical Oral Investigation, one of the nice journals in dental field. They investigated through all over the world, and total of 675 dentists participated in this survey. Among them, around 20% was general dentist and 80% was endodontic specialist. As a result, more than 80% of general dentists have already heard of bioceramic sealers, and almost all endodontic specialists have heard it. Also, more than 60% of specialists and 40% of general dentists have used it. It means that bioceramic sealer is already widespread all over the world. Next question was why they used the bioceramic sealer. More than 87% of dentists use bioceramic sealer because they believe it has a good biological and physical chemical properties. Interestingly, more than 35% of them also expect the bioceramic sealer can fill possible perforation, especially stripping perforation. In other words, they consider bioceramic sealer has the ability to repair perforation without harmful effect on the periodontium. Some dentists expect to save the filling time or simplify the equipment. Anyway, we can recognize that lots of dentists already have a positive stance regarding the bioceramic sealer. To top that off, from my standpoint, we need to think about the presence of moisture in the root canal. If the moisture is controlled adequately, any type of sealer is okay. But not all cases provide perfect dry condition. Furthermore, even though we try our best to dry the root canal completely, we cannot remove all the moisture in the dentinal tubules. So, the moisture remained in the dentinal tubules may affect the performance of a resin-based sealer. As you know, resin is very susceptible material to moisture. According to many previous studies, bioceramic sealers shows a very favorable performance even in the presence of moisture in the root canal. Notably, this graph shows that the iRoot SP, the bioceramic sealer, maintained its bonding performance even in the presence of moisture. In this respect, I strongly suggest to use bioceramic sealers if the situation permits. Let me summarize the hydraulic bioceramics. It has excellent sealing ability, physical, chemical, and biological properties. Also, the handling property was enhanced. Therefore, I would like to say that the hydraulic bioceramic materials have the potential to be used successfully in the endodontic field. How about using these materials right now in your clinic? Thanks for watching my presentation, and if you have any questions, please email me. I'm ready to share my knowledge with my precious colleagues. Have a nice end of the day. Bye.